Welcome to Chamber Talk, brought to you by North Orange County Chamber, where we explore the stories and insights of leaders, business owners and CEOs from various sectors who are making a difference in our community and region. Whether you're tuning in via podcast or joining us via video, we're glad to have you here. Welcome to Chamber Talk. I'm your host, Andrew Gregson, and today we have our founding director and CEO of Healing to You, Cari Teran. Thank you for coming on today, Cari.
Thank you, Andrew. Thanks for having me.
There's so much that you do and you've done in your work in the world so far. So before we get on to Healing for You, do you mind sharing a little bit about your background so people know what you've actually done professionally over the last few years?
Yeah. So I've been a licensed marriage and family therapist for the last 25 years, working with primarily children and families who have experienced trauma or violence. I spent a couple decades in community mental health in Los Angeles County, moving through clinical supervisor, program director, and just supporting families through intensive services, in-home therapy models, going to schools, helping with advocacy and case management. And I ventured into infants and toddlers. So I got trained in evidence-based models for 0 to 5. So a lot of foster care families, infants and toddlers who are in foster care because they had been abused. And so I would work with them and their caregiver, their foster parent or relative caregiver. And then COVID hit, which made working with infants and toddlers in their home very difficult.
Right.
Yeah. So I kind of went into semi-retirement and did private practice through telehealth and was very kind of comfortable, but not quite challenged or
right.
And I saw a huge need. The majority of my private practice clientele were adults who had a very complex or lengthy history of trauma. So they would, with complex trauma, it's not just one type of trauma. There's multiple, it's layered. It's typically over a long period of time. And so the adults I was working with were healing their wounds from their childhood. And typically it was, 10 to 20 years of abuse. So that takes a little bit of time. And what I was noticing is chronic health issues.
Okay.
So a lot of my clientele were just struggling with autoimmune disorders, blood pressure, diabetes, obesity, you name it, they had it. And I was witnessing their struggle in accessing healthcare and noticing how our mental health and our physical health are so related. I'm also, I have a niche in abduction, recovery, and treatment. So some years ago, I kind of stumbled into that work, and I am now the vice chair of our California Child Abduction Task Force under the governor's office. And we are a multidisciplinary team that provides training, support to law enforcement, first responders on essentially how to mitigate trauma in child abduction cases, and also how to quicken their recovery. And my role is to train our community partners in trauma-informed care and ensure and support that our law enforcement and our first responders are trauma-informed when they're working abduction cases.
That makes sense.
Yeah.
So you mentioned there a little bit about you worked with infants, young kids from 0 to 5. A couple of weeks ago, we had Kim Goll on, who runs First 5 OC, which you probably know very well. Is there a reason why, like for her, it's the first 5 years the most important? Is that what you were looking at when you were going through your mental health type of thing? Is that why? Or
Partly, yes. I feel like they're also the most vulnerable,
Right, that makes sense.
right?
Right.
And mental health for a 2-year-old um, is not commonplace,
Sure.
but they need it,
Right.
right?
Yeah.
And there's a beautiful model called child parent psychotherapy that works with the dyad, the parent and the child together, and it looks at how the child, how the trauma has impacted their body and their regulation. Um, and I was also seeing in my private practice, we adults struggle with our emotional regulation
Mm.
when we're in trauma or when we're activated or something's going on. And and I thought, well, we need to just get back to the basics. If we can
Right.
help this infant or toddler regulate and kind of heal those wounds as much as we can at that point, then that might really set up their trajectory for a more positive experience in life.
Now, I'm only guessing here because I really don't know, but I'm assuming it's very different between toddlers and adults. Is it more to do through play or how they act out or what they do that gives you the signs of which road you need to go down to help?
Yes,
Right.
yes, it's fascinating. I've been doing play therapy with all ages, and that's wonderful in and of itself because it allows the child to essentially act out the themes or issues that are troubling them.
Okay.
And
Like almost like a role play type of things?
oh yes,
Oh, wow.
yes.
Okay.
Anytime children are in role play, they're in imaginative play.
Oh, okay.
And you can really get a sense of what a child is going through based on what they play.
Oh.
So if a child is wanting to play teacher or school,
Right.
you know, they may need a sense of mastery in their environment. They may need to be in control. So it's kind of looking at the themes that are underlying the play.
Right.
With infants and toddlers, because they typically aren't verbal and their play is different. We look at their physiological regulation. For instance, when babies are holding on to anxiety or stress, they'll cry, they'll scream. You know, that is kind of their only way of getting their needs met. And so we look at how well the baby is able to regulate, so to speak. For instance, let's say a child has been drug exposed in utero. Their physiological system may not be able to calm itself on in an effective way.
Okay.
Right. So there was a case that was this. So an infant who was drug exposed in utero and not getting fed, and parent was not taking adequate care of their body, not getting rest. And so what that did is that caused the infant in utero to get really upset very quickly because their needs weren't getting met.
Right.
So when they were born at 3-4 months, they would wake up and just scream for an hour. They couldn't regulate enough. They weren't used to food being provided
certain time or anything like that, right? Okay.
And so what we did is we looked at, okay, what are these challenges with regulation, and what is possibly the trauma that's underneath that, and how can we address that and kind of repair that story for that infant. And you'd be amazed. Sometimes just talking to the baby and saying, I know that sometimes when you were in whatever the language might be, mommy's tummy, that you didn't always get food. And that was scary. And now you're worried when you're awake, that you're not going to get food. And you might be thinking, you say this to a 3-month-old, and we do.
Right.
And I have had infants just stare at me and take it in, and
well, I'm sure the voice is calming. Everything's sort of like a calming thing, and then as routine, I'm assuming is very important at that stage, is it?
Yes.
Right.
Yes. And so there's a lot of assessing for appropriate developmental levels, making sure they're kind of on track with
Right.
their markers, and providing that support as well, so that everything can develop all at the same time.
Now, you also mentioned that, through your experience here, you quite profoundly saw that there was a big sort of match between mental and physical health. Mm-hmm. Would you like to share, or could you share a little bit more to our listeners about that, about how the importance of them joining them together?
Yes. So if, when you think about it, when we feel distress or anxious or upset, our heart beats faster, right? We go into fight or flight mode. Mm-hmm. And that is a physiological response in our body.
Right.
And when, for instance, if we are exposed to trauma, either early or over a length of period of time, that constant activation of our system, that flow of cortisol and adrenaline over a long period of time does damage. And what happens is our body gets so quick to dysregulate that we have a hard time calming down.
Right.
And that, of course, will impact our physical system, right? We get stomach ulcers, we get indigestion when, there's constant stress in our stomach.
Sure.
And when you have those chronic issues, that turns into chronic health problems, right? Like we end up with high blood pressure or maybe blood sugar issues or diabetes. And so there's a lot that needs to be folded together. I don't see healthcare as just physical health.
Right.
Yeah. Healthcare really needs to be the whole
thing. It's like a full circle.
Yes.
Yeah. Just you. Right.
Yes.
Right.
Yeah. Because we are complex.
Yeah.
We're not just one system.
Sure.
Know?
Well, feelings make your chemicals change in your brain, which make you act differently or feel differently. And so it totally makes sense that. So moving a little bit into Healing to You, which you're the founding director and CEO of, could you share, because it is quite a fascinating story, but share how that came about? Because it's not quite normal for people to run around in a big old motorhome and help people, is it? Really, it's quite the different thing.
I don't think it is normal.
It's not quite normal, is it? So, it's a beautiful equipped vehicle as well. I must admit, we were lucky to see that when you first got it. So, do you mind sharing a little bit about the story? Because it is very nice.
So how did we get to Healing to You? So during my semi-retirement and private practice, right, I am seeing all of these chronic health issues in my patients and finding that we're spending a lot of time in our sessions just helping them navigate the physical healthcare system. Mm-hmm. I don't think it's a secret that our healthcare system needs some work here.
Sure. Right.
And I myself, prior to COVID, actually was diagnosed with melanoma, and no one told me. I had a freckle on my nose that I was doing field work with children, and so sometimes the home wasn't safe, so we'd meet at the park or elsewhere, and I started noticing a freckle right in the middle of my nose turning weird.
Okay.
Just getting a little darker after being in the sun. And so I followed up with my dermatologist, and they did a biopsy, and no one called me back or followed up. And then they referred me to plastic surgery, and I was like, what is happening? And ended up reading the referral that I had melanoma.
Oh my gosh.
Mm-hmm. So that was horrifying, and I'm so grateful. It was small. It was nothing that required anything more than surgery.
Sure.
And I'm grateful that I got to keep my nose.
I think it's also lucky that you got some type of understanding in the medical world, because a regular person probably wouldn't have even thought about doing that. They'd have just gone to the appointment.
Right. Well, and I had to really fight for it, to be honest with you. I had an HMO at the time, and they were referring me to a breast surgeon.
Oh, wow.
And I was like, I think it's on my nose.
Right. A little bit far away. Little knot.
Yeah. So let's make sure we're working on the right thing.
Wow.
And it really took a lot of advocacy on my part to get the right surgeon, to get the right care. And I had to switch dermatologists 3 times just to make sure that someone's calling me back.
Right.
So with my personal experience with that, and then seeing what my clients were going through, it was kind of a no-brainer,
Right.
you know? And so there was an opportunity to write a grant for the state to provide mobile health care to domestic violence shelters.
Okay.
And I thought, oh, wonderful. What a wonderful
What a great
opportunity.
idea. Right.
And I have previously worked at domestic violence shelters in LA County. And so I reached out to some of my friends and partners there and asked, hey, do you know about this grant? Are you going to write for it? And no one had the staffing, the time to do it.
Right.
And then I started asking, well, what do you all do for healthcare? You know, it's been 20 years since I've been in a shelter.
Yeah, right.
Hands-on. And they said, oh, you know, urgent care, emergency room, clinics. And I thought, oh gosh, nothing's changed in 20 years. You know, if you think about a family who's just left a violent situation and children need physicals to be able to get into school. If a parent has not grabbed their immunization card, they need immunizations.
Right.
And so typically they're referred to, I don't know, a community clinic or an urgent care. And in all honesty, physical health isn't at the top priority when someone first goes into shelter. They're typically concerned about safety, restraining orders, where am I going to live? Am I going to work? Will my kid get into school?
Right.
So that I can have the time to do
very
all
low
this.
down on that list then.
Very low.
Right.
But we know that there are chronic health issues when you're exposed to chronic stress like that. Sure. On top of the fact of the physical violence threat, right? And that there may be physical injuries or repeated injuries that have been overlooked or untreated. And so when I found that out, I thought, oh, this is a travesty. This needs to be written and someone needs to do this. And so I marinated on it and kind of said, well, what will it take to start a nonprofit and create this kind of model? And the stars aligned for us. We were able to form this nonprofit and write for this grant. And we were awarded the grant for San Diego, Riverside, and Orange County.
Oh, congratulations on that! And what made you steer towards definitely a mobile unit opposed to being, you know, bricks and mortar, so to speak?
Yeah, the mobile clinic is a way for us to really reach out of the way shelters. You know, location can be so hard.
Right.
Shelters are often spread out.
Sure. Right.
And so to be able to access each of them, the mobile clinics just kind of made sense.
Right.
Especially after COVID, there was just more opportunity for mobile clinics.
Sure.
More mobile clinic producers and things of that nature. Regulations allowed licensing of standalone mobile clinics. So things had just shifted and really supported our mission in that way. With our mobile clinics, though, you know, because a lot of times, I mean, obviously shelters are confidential. And so we couldn't just roll up in the big bus, 38-foot mobile clinic and, you know, park next to them.
Sure.
So we typically park away from the shelter, and then we have a passenger van that can transport.
Just shuttles folks over. That's really good. So on that point, because, you know, we'll keep talking about it and there'll be bits to come up now and again. Do you find it a challenge finding places to park your bus? Do you need help with that? Is there cities that can reach out to Healing for You and say, hey, you know what? If you're coming around here on a Thursday, we've got a car park? Or
yeah, parking is actually our biggest challenge. Some shelters have public administrative offices, so we're able to park there. Others have, you know, partners that allow us to park. But it is challenging. You know, different city politics have different rules, and
So if anybody's listening and they work for the cities or the county, it'd be really helpful if they could reach out to you and provide some safe, adequate parking areas sometimes.
Yeah,
That'll be good. Okay, that's good.
That'd be wonderful.
Now, you were mentioning there, which I think is a very smart idea. Obviously, you are parked away from the center or from where the patient's clients or whoever you'd like to call them visit you. And obviously, unmarked vehicle picking people up, traveling out makes total sense to me. What types of services are you actually providing to these patients or clients or visitors? I don't know what you'd like to call them.
Yeah, we call them patients.
Okay.
Yeah. We have comprehensive care. Our 38-foot mobile clinics have 3 rooms. The first room in the center is our medical assistant and intake triage room. So we have a lot of health screenings, rapid screenings that are the finger poke screens. So we can test for A1C, glucose, STI, STD, HIV, cholesterol, and all of those results are done within 20 to 30 minutes.
Oh, really? There on your
right
your,
there,
wow.
right on the spot.
Oh my goodness! Makes you wonder what hospitals are doing, doesn't it?
Right.
Sorry.
It's it's fascinating how accessible healthcare could actually be.
Right. Yes. Yeah. If you just thought about it a little bit. Right.
Yeah. And these machines are not super expensive.
Sure.
They take up very little room on our counter.
Right.
And then we have a medical room. So we have a mid-level medical provider, a licensed nurse practitioner or physician's assistant who can do all primary medical care for adults and pediatrics, physicals, immunizations, pap smears, whatever exams needed, vision, hearing screenings. And then we have our third room is our mental health room.
Right.
And so we've just got a ton of toys in our cupboards based on what issue is presenting.
Right.
And so we typically have the medical professional, the medical assistant, and then a mental health clinician. We also have a site coordinator and operator who drives the actual mobile clinic, sets it up.
Right.
And they do the transportation for the patients back and forth in the minivan. We, aside from providing transportation, we also provide childcare.
Oh, wow.
So a lot of times families will come in with multiple children.
Right.
And maybe mom hasn't had an exam in years.
Right.
She doesn't need the children in there.
Yeah, it's going to take a bit, isn't it? Right.
So we will provide therapeutic daycare while mom is getting her exam. And
that's nice.
It's worked out very lovely.
So if somebody requires like follow-up care, is that something also when you come back in town, let's say, that you continue with that? Or is it you find then, because you were saying you really help people like get into the system and where they need to go. Do you sort of like give them local doctors or centers that they can go to?
Yes to all of it.
Okay.
So we do both. We typically folks in shelter, in emergency shelters, will stay 30 to 45 days.
Right.
And there's so many circumstances that can come into play with how long a person stays.
Right.
So we typically see the same shelter, each week. And there are times that a client might just get into shelter the night before. So we're seeing them pretty quickly. Or they may be there just for a few days.
Right.
So we never know if we're going to see a patient or their family once or 4 times.
Okay.
If they transition into the shelter's transitional living services, then we have an opportunity to see them continually because we do service the transitional shelters as well.
Right.
If they need services that we can't provide, then we connect them immediately to whatever's in the community. Right. One of the more lethal and challenging things that we've been seeing is strangulation and suffocation within domestic violence.
Really?
And it's a huge problem
Right.
that's kind of gaining some attention in the
Right.
media. Law enforcement is changing how they view it and
Okay.
how they respond to that.
Right.
And so we know there is a high co-occurrence with sexual violence and strangulation and domestic violence.
And is this something that suddenly you've noticed has increased, or it's something that it's just become more prevalent?
I think it's always been there.
Right.
It's been there since the 90s when I was in the shelters, but
Right.
I feel like I don't know if society is ready to hear it now.
Sure.
I don't know. I know that, there's been some.
Well, if you don't hear it, you don't learn about it. If you don't learn about it, you don't do anything about it, do you?
Yeah.
So it makes sense, right?
And one of the biggest problems with domestic violence is it's not discussed.
Right.
We don't talk about it.
Yeah.
But I think that, in the last 10 years or so, there's been a lot more media attention on this and a lot more work on the part of domestic violence advocates and making sure that this gets addressed. So there's been some legislation that has supported law enforcement ensuring that victim survivors get assessed or checked for strangulation and suffocation.
And has this changed what you offer at the clinic? Is that what you were getting at? Sorry, because we interrupted you there.
No, that's okay. That's okay. Yeah. And so because I've spent quite some years in a community mental health agency that also had a pediatric sexual assault response team.
Okay.
So when a child is sexually abused and they've got to get a forensic exam at the hospital, we would have advocates, volunteers, angels on this earth is what I would call them, to sit through a forensic exam with a child.
Wow.
I mean, literally sit through it and hold their hand. And so I know there's such a high co-occurrence. And when we have a home with domestic violence, the rates of child sexual abuse also increase significantly. So we thought it was necessary and important that we add those services to our medical clinics as well. So if we have a client patient who comes in and during the physical exam, maybe the practitioner is finding bruises on their neck, maybe there's a raspy voice, that is an indicator.
That's an indication. So it's not always you see the sign. You're not always seeing physical marks, but there's the damage behind it.
Yeah, and that's one of the biggest threats with strangulation and suffocation is there's so many tiny little bones and muscles in our vocal cords.
Could be a lot more damage than what you really see, I'm assuming.
Absolutely.
Right. Wow.
And so as soon as we started rolling out our mobile clinics, I want to say our second patient had some strangulation.
Oh, wow. And
so we kind of immediately sought out training. Our medical providers are now trained in doing the forensic exams, and our mental health clinicians have 40 hours of sexual assault advocacy training. We're actually producing both a 40-hour domestic violence course and a 40-hour sexual assault advocacy course for victim service providers throughout California so that we can expand this awareness and this training so that there can be more services out there. Our hope is to extend to rural cities and clinics and get more of these advocates and more forensic services out there because there just isn't enough.
So I'm guessing when you're mentioning earlier that, you offer training to the emergency services, in particular, maybe the police, because they're one of the first to respond, perhaps even the medical first responders from the fire departments, what have you. Is part of the training now learning that it's not just physical what you see, you're having to listen to, is it a raspy voice from heavy smoking, from is that part of this training you're talking about?
Yeah, well, our providers have received the training to conduct the actual exams, but as in my role with the Child Abduction Task Force, when I am training law enforcement or FBI or child protection workers, victim advocates and district attorneys' offices, these are the things that I explain.
Right.
That when you are responding to a call and this is what you're encountering, make sure you're also assessing for, yes, the throat, the voice,
and other bits and pieces that go on. Welcome to Chamber Talk, where we shine a spotlight on businesses, non-profits and leaders that keep the community thriving. However, let me ask you something. Why isn't your business sharing the same spotlight?
That's right. This ad, the one you're watching right now, could actually be yours.
Imagine reaching our engaged audience of local movers, shakers, decision makers and residents. Learning all about your business with your message right here.
It's like being the guest star of your favorite show, except this one's all about you. Want to make your mark? Advertise with Chamber Talk, because every great business deserves its moment to shine.
So it sort of ties in a little bit. So the other day we were meeting with Radiant Futures, and because it's Human Trafficking Month in January, and we were talking a lot about it's not always just border stuff; it's internal, domestic, and so on and so forth. Sort of ties in a little bit about what you're doing. One of the questions I have, I suppose, when you're meeting with, folks who are either at the shelter, wherever they've come from, or whatever, it could be human trafficking even, that they're coming through your clinic, because medical is so large, and obviously you're making some type of record. Is there sort of like a database that you keep or records go to, so then if somebody ends up at a hospital, at least they can see back some history, or is it too private, or what? Is there some way of helping out so we can see a trace there somehow?
We have an EHR, so
Right.
all of, we keep all of our records and patient files in there.
Right.
Should the patient go somewhere else and need access to their chart, they can do that. They have that control or power.
Right.
And we definitely coordinate with the hospitals, and we see ourselves as kind of gap fillers.
Sure,
and so
sure.
we want to make sure to make that connection.
Right.
A lot of times our families have not had any medical records. When you're living with violence in the home, going to get medical care is not
It's not on your
supported.
things to do, is it? Right.
Well, and it's often discouraged.
Right, of course.
Right?
Well, you'll
Because-
find out about it, won't you?
Yeah, doctors will see those bruises.
Yeah.
Children might say something. So these families are really undertreated, underserved, under everything.
Right.
Underinsured. And sometimes there's challenges, and right now our services are free for everybody because we're covered through the grant.
Sure.
And that worked out quite well because a lot of survivors don't want to use their benefits. There may be fear that their abuser has access to their...
And would see it.
Yep.
Yeah, that
Yeah.
makes sense. That totally makes sense. So talking about grants, that's a good segue there. With everything that's going on, it's a lot more difficult finding funding and grants right now. What happens for you for that? What's your next stage for finding advanced funding?
Mm-hmm. Well, we are opening a brick and mortar.
Right.
So we've got a Wilmington Comprehensive Community Clinic in South LA in Wilmington. And that will be kind of our revenue generator.
Okay.
It'll be a full community clinic with primary care for the whole family, mental health services, psychiatric services, and we're going to have a 24/7 SART center.
Oh, okay.
So if law enforcement or hospitals need a rape kit done, then the patient client can come to our clinic. With my experience working in community mental health, specifically in LA County, South Bay area, there are a lot of abuse disclosures that come out in therapy. So when you have an attuned and well-adjusted clinician, right? Not anyone who's stressed and overworked and
Sure.
can't get to anything. But when we have clinicians who can really sit and be with a client, they know that. And so they're more likely to disclose things that are going on currently in the home.
Right.
So my experience informs me that we're going to probably have a lot of disclosures, you
Right.
know, and that if we are a base, if you will, right, a sexual assault treatment center, that we'll be able to provide that type of forensic service and advocacy and connection to the district attorney and support with prosecution, because our goal is to ultimately interrupt this,
Of course. Right, right.
violence. Yeah.
Yeah.
It's one of the reasons why we like working with them young, to hopefully really interrupt that.
So is it also with this new bricks and mortar clinic? Will you also be, if people are coming in, they may then continue to be a patient longer term, because obviously you're already geared up for all the other side and assistance and support that people need.
Yeah.
Is that also part of that plan?
Absolutely. The thought is, if I'm a child and I'm being abused or things are unsafe, I'm not gonna go tell some random adult, but I might act out. Right? I might have some behavioral problems.
Yeah, which you don't know if they're a toddler. could be either way, right?
Right.
Yeah.
And so typically the parent will say, oh, my kid's acting out. Here, I need some behavioral health therapy.
Right.
And then we get in there and realize, wow, there's a lot going on in your family, and maybe these things aren't quite safe. And then the child can disclose, yeah, this is really going on. We're already the trusted adults, and we have all the services under one roof. If a forensic exam is needed, they can do that.
Right.
If they need follow-up medical care, which I'm sure they would, right? They can keep coming back to their pediatrician.
Sure.
And then if they need, higher levels of care or different services, we can connect them and get them going with that.
Now, obviously, big thing right now, it's all over the news everywhere, and it's on people's minds about health insurance. And this sort of ties into, what you're talking about here. I'm assuming not every health insurance provider will necessarily give people cover for this. And also, as you mentioned earlier, a lot of people don't even have health insurance. So how does that work for folks who are coming into the clinic at that time or looking to make an appointment?
We serve folks who are uninsured.
Right.
So if they don't have insurance, then we will treat them regardless of, age, race, coverage. We really, our primary goal is to increase access to quality healthcare. There may be doctors out there, but are they quality doctors?
Right.
Are they trauma informed? And let's face it, everyone has had some kind of trauma. It's pretty rare to find someone who hasn't had something.
Experience something. Right.
And again, kind of going back to what my patients have reported, and when they share with me these things that doctors have said to them, or the way they've dismissed some of their symptoms or their issues, it's just heartbreaking.
Right.
And so we are really set out to do things differently. We want to make sure, I don't care if you have Medi-Cal, if you're uninsured, or you've got a platinum PPO, you're going to get the same level of care at our facilities.
And will there be, going forward, funding available for clinics like yours, or particularly the mobile center, because that is very, very helpful?
Yeah. So federally qualified health centers, or FQHC, are federally funded to provide free services to folks in the community. We're hoping to apply for that down the road as we get situated.
Sure.
There are county contracts and things that all of our services would be covered, right? So either paid through Medi-Cal or their private insurance. None of our services would be uncovered by a health insurance. Right. So we're hopeful that this brick and mortar can provide the revenue that is needed to sustain our free services.
And the revenue comes from the programs that are adopted. Is that the idea? Right.
Yes.
Right. Okay. And I'm assuming you're often looking to see if other medical professionals would like to be a part of or draw together. Is that right? Or yeah?
Yeah.
Is there anyone in particular you're looking for right now? Or
Yes. Well, we are in our final stages of approval with the Department of Public Health for our LA clinic, and we will then be looking to hire. So we will be looking for bilingual Spanish-speaking medical providers and mental health clinicians, nurses, medical assistants.
the full 9 yards there.
All
That's
it.
beautiful.
Mm-hmm.
That's lovely. And is there a glimmer of a because they're not cheap, a second mobile clinic in the future? Is that?
Well, we have two already.
Right.
I don't know if we are going to expand our mobile clinics,
Right.
but we are looking at expanding our reach with the mobile clinics.
Oh, I see. As in where you're driving to or where you're going, right?
Yeah, we're constantly picking up new partners. We've
bet.
got 2 new partners this month,
right?
To reach out to, and
well, shelters are popping up everywhere. I mean, it's more common today than it was some years ago, so it makes total sense.
Yeah. And we also we expand our services beyond just domestic violence shelters. So one of our partners is Wise Place, which is, services for adult women, and they accept pets.
Right.
And we also partner with Orangewood Foundation for their homeless teen outreach center. So we see a lot of transitional aged youth, that like 16 to 24 age, who are living on the streets.
Wow.
The reason they're living on the streets is typically some kind of trauma or abuse at home.
Sure.
So we are grateful that we can, extend those services to include victims of any kind of abuse or trauma.
Now, the clinic itself, going back to the clinic itself, so the clinic itself, regional usage, that's not easy, is it? I mean, you're in LA, you're based in LA. You're based up here towards Fullerton area, but let's say you're setting off. San Diego's a couple of hours to get down there. It's a couple of hours back. I'm assuming, is it one, Riverside's also your other area? I mean, strategically, what's the challenges with that? That's not that easy, is it?
No, it's not.
It's like week on, week off. I mean,
we have currently 12 partners, and we operate 6 days a week.
Oh, wow.
So essentially, we could visit each partner 1 day a week.
Okay.
With our 2 clinics, one lives in San Diego, and then one lives in Orange County.
Oh, so you can cut it in half almost there, right?
Yeah.
Right.
And ironically, our shelters out in Riverside are the exact same distance from each clinic.
Each clinic, right? Okay. So whoever's unlucky to be free that day is going out to Riverside.
Yep. That's pretty much it.
Oh, that's cool. That's cool. Now, you do also have a bit of a nice story about Healing to You because you've got the blossom tree in your logo and everything. And I remember slightly, because it's a couple of years since you had your open day here and you did your ribbon cutting, but I do recall that it was a lovely story. You want to share that with us?
Yeah. So I'm a quarter Japanese. My Obachan, which is grandmother in Japanese, and I were very close. She was this babysitter for me when I was 0 to 5. And so her and I always had a special kind of bond, a connection. We just kind of understood each other. And growing up, I just knew her as my sweet little Obachan who had purple hair. She was one of those Japanese women that she had the same hairstyle from the 60s, and it had a purple tinge to it, and I loved it. And as I got older, she had some health issues, and she ended up actually recuperating from a quadruple bypass with me in my house when I was in my 20s. And we ended up, I was working at Long Beach Women's Shelter at the time, and we would chat every night, watching her samurai shows, and she would ask me about my day, and I would keep it, I would spare her the trauma. But I could kind of hear her mumbling under her breath about things, and my aunt would share things about their childhood. So I didn't grow up knowing my grandmother was a victim of abuse, as far as the details, but I knew that that my grandfather was not a nice person.
Okay.
And during that time that she was recuperating with me, I learned a lot more
Oh, wow.
about what they endured. They met. I got to say, my Obachan was quite the rebel. So in 1940s Japan, she actually had an arranged marriage and refused.
Oh, wow.
Yeah, she
It's
said
not often
no.
you hear that, is it?
Yeah, no, not at all. So she said, no, I'm not doing that. And then during World War II, she met an American soldier and they fell in love and got married and had, had my aunt and then had my dad in Hokkaido. And then they moved here and then the abuse started.
Oh.
And he was a drunk, he was an alcoholic, and he was horrifically violent. He also went on to sexually abuse my aunt, and I have permission from her and my dad to share all of this. And so I learned all of this in my adulthood as I was working with survivors in a shelter, and it was just profound.
Right, right.
Imagining my beloved grandmother, new to this country, did not know English. So my aunts and my dad had to be her translator. She ended working in a shop in Little Tokyo and would take the bus every day. And I was in awe of her,
right?
Her strength and her resilience. And honestly, it wasn't until after she died that I learned how she finally actually left him. And it just blew my mind. So as this 5'1" Japanese woman with 3 young children, I think my aunts and my dad were between 10 and 12.
Right.
She left him. She left him, got her own apartment. I don't even understand how, right? This would have been in the late 50s.
Right. Not a normal thing to do at all for people back then, was it?
Not at all. And
no.
If you can imagine the hate for for Japanese
as
at
well,
that time.
still after the Second World War,
yes,
sure.
Yeah. So she got situated. There was a time that he showed up, my grandfather, and was drunk, was waving a knife, and my dad at the time actually kind of jumped on him, and it was pretty stressful. And my grandmother said, hey, look, let me just cook you some food. She could always kind of calm him down, I guess, with food. So she got him to calm down. She fed him food, and he left. And she never heard from him again.
Wow.
I'd never met him, obviously. And so I just knew my grandma, my Obachan. So learning all of this, I just had so much more respect for her. And when I was thinking of, when I was forming this nonprofit, all I could think of was her.
Right.
And that this was in honor of her and for her. And really, these are the types of services that her and my dad and my aunts needed at that time and didn't have access to. Because of that, my aunts and my dad struggled with substance abuse and mental health issues and untreated trauma, so physical issues, and I've witnessed that impact on their entire lives.
Now, I've heard it before, so I'm not asking if it's true or not. I suppose I'm more asking is it like a factual thing? Is if parents or grandparents have gone through trauma or there's been trauma in the family, is it right in believing that sometimes that can be, not necessarily even if it was physical or what have you, it can be spearheaded into the kids and grandkids as well?
Sure, yeah. And if you think about it, it's not necessarily the overt violence. I mean, sometimes that gets translated, right?
Yes.
But it's these emotional dynamics that get transferred.
So the triggers that might trigger them on something will then be yours later, or you see it or act differently with it.
Yeah. If you think about the dynamics within abusive relationships, I don't like the word victim, but it's what's utilized out there, right? So we see survivors who have to take care of things, right? So when there's an abusive relationship, the abuser is the one who is seeking the power and control and asserting that power over someone else. And the survivor is really just the peacemaker, right? They're walking on eggshells. They're trying to make sure nothing upsets this person. They become a codependent caretaker.
Right.
And so that codependency is kind of what we see transferring through generations. You know, I was a caretaker in my earlier life,
Sure.
early adult,
Yeah.
and you know, that doesn't play out well in relationships. And I'm grateful for the marriage that I had and the children that I had, and also the learning, you know, that I was able to gain from that. I was able to recognize patterns or behaviors in relationships that I brought to it that, you know, through a thin string were tied to that generational trauma. And once I could kind of heal that, repair it, and step out of that role, it was life-changing.
Right.
You know?
So I'm assuming there you're talking about therapy. You should seek out a good therapist, I'm assuming, and try and work through those things. Now, that leads us into another good topic, because there are quite a lot of therapists out there these days, but not all of them, maybe, just like any other business, aren't maybe the right ones for you. What sort of advice would you give from somebody, particularly as you've understand this personally as well, how to find the right type of therapist for yourself? Boy,
and therapy these days is such a hot topic. There's a lot of venture capitalists coming out, right, with kind of online therapy programs.
Sure. Yeah, there's a lot of those, yeah.
And they're not good.
Oh.
There's been a lot of issues with them because they're not looking at healing. They're looking at numbers.
Okay.
Right. So they want to see how many patients they can serve, how many are fixed or repaired in the shortest amount of time. And unfortunately, they're doing things with data that are not ethical. They're also not following clinical license ethics.
Okay.
So as a licensed clinician here in California, I can only see client patients in California. Some of these bigger companies.
Of course, you could be anywhere, I'm assuming.
Yeah.
Oh, right.
And so now I could be in Florida.
Right.
But I can only see people
somebody
here in California.
here. Right. That makes sense.
But what these big companies are doing is they're just having people see anybody anywhere. Sessions are being recorded. And sadly, they're taking those recordings and they may not always be secure.
Oh.
So your most intimate trauma details, now who's listening to it?
Right.
And then they're also utilizing this to create AI therapy, which is dangerous if you ask me. If I've got a client or patient who might be suicidal,
right,
and they're texting some AI app as their therapist,
sure,
who's going to do that threat assessment?
Yeah, so and there's only so many answers I'm assuming AI could give out, and you don't know, you're not feeling the temperature of the individual at the time. I'm assuming that's the difference, is it?
Yes.
Right.
So my suggestion for folks is always, we got to think about who's paying.
Right.
Right?
Yes.
Who's going to pay for the therapy?
Right.
Insurance.
Yes.
Your insurance covers therapy.
Yeah.
Now, one of the challenges is insurance companies are creating this kind of monopoly. So they are closing panels, so they don't bring on new clinicians. And then, of course, the clinicians who are paneled with the insurance might be full because there aren't enough of them.
Right.
And so then they say, oh, well, we don't have enough. It's really not true. There are hundreds of thousands of wonderful clinicians out there, but they can't take private insurance because they just don't get the referrals.
Right.
So unfortunately, the options are check with your insurance.
Okay.
And it's always about the fit, right? So if you meet with someone and you're like, ooh, they're not listening to me, or I actually had a new therapist during COVID who was reading something as I was
I wasn't even paying attention to you.
They were reading as I was sharing about the death of my father.
Oh, shoot.
I mean, it was really awful.
Right.
and I thought, oh, I'm not seeing this person again.
Right.
And so people need to really trust their gut. You know, sometimes it takes shopping around for a clinician.
I can imagine that. You're not going to find the right person straight away.
Yeah. And people get frustrated, and there's wait lists, and it's just hard.
Right.
There are private practice clinicians who will do sliding fee scales and do reduced rates. And so if you can find those, but there's a lot of community organizations that do have pro bono or free therapy. It's just a matter of trying to find them.
And then how does one decide or have at least some type of idea of what type of therapist they should meet with? Or because that's not, you're not going to know yourself right now, otherwise you'd have fixed it, right? So how do you come about that? How do you determine that?
You know, there's that's a good question. You've got me stumped there.
There's no like little tests you take and they go, oh, you should go with this type of therapist or that. You know, I mean, it's I'm glad I asked a stumping question.
Yeah,
so
you stumped me today.
Those. All right, okay.
You know, typically, like if I were to look for therapy, you could select issues sometimes,
okay,
right?
Right?
So sometimes there might be an advanced search engine that you can say, I want grief.
Right, okay.
Right. So sometimes you're presenting the issue.
Sure.
But then sometimes you might look into, well, do I want group therapy?
Right.
Do I want individual therapy? Do we need the whole family to come in?
Right.
So those two things, along with funding, are probably the top three that you would look for, right? What issue do I want to address? Who do I want in the room? And who's paying for it?
Right. That makes sense.
Yeah.
That helps you out then, doesn't it?
Yeah.
That makes sense. Well, and with we were talking before, and I'm sorry I'm jumping back a little bit, but it just popped in my mind there because you were talking about, obviously you work with 20 or so different organizations. Are you at the stage where you can still work with more organizations? Are there other people who might not know about your services and you'd be happy to share with them about them? Or?
Yeah, absolutely. We, there are some of our partners that already have mental health services within their organization.
Right.
So then we kind of come in and just do the medical services. We do have space to add more partners. So if there are other community organizations who
wish to partner
have
up,
a need, please.
And then they
out.
can just literally go to your website and contact us, and then somebody will reach out to them today. This has been really interesting today, and we always get to a point in our talks where we offer the guest time to, whether we might have missed something they might want to talk about, they might have a final word, whatever it is. It's like an open mic moment here. So please, share something that whatever you're wishing to carry on with or finish off with or whatever.
Well, I so appreciate you having me on here and giving me this opportunity to share our story and our services. We're in this year of growth, and expansion. And so we are looking for, supporters, foundations. We are actively writing grants. So if there are organizations out there who like what we do, we would love to partner up. We are also open to hospital sponsorships and, looking at how our mobile clinics can
be an extension of what they're offering. That makes sense, right?
Yeah.
Well, that's good. That's excellent.
Yeah.
Well, thank you very much for being here today. And thank you to everybody who's been watching or listening. If you've enjoyed today's episode, don't forget to like, subscribe, and share. Stay tuned for more inspiring conversations on Chamber Talk by visiting nocchamber.com and select Listen to Chamber Talk or select Podcast at the top of the page. Until next time, stay inspired and keep making an impact.